This is a video presentation of a robotically assisted, minimally invasive L4 to S1 transforaminal lumbar interbody fusion. A 49-year-old woman presented with a chief complaint of chronic back and buttock pain and foot drop for 1 year. She experienced progressive lower back pain after a fall from a 3-foot deck 15 years ago. The pain radiates horizontally across both buttocks and anterior to her groin, worse on the left, and is aggravated by prolonged periods of walking or sitting and alleviated by positional change. She reports a subjective sensation of left leg weakness and endorses occasional buckling of her left leg. She denies loss of bowel or bladder control. She has a history of multiple injections, most recently an L4-5 facet injection and L5 transforaminal epidural steroid injection without any relief. Physical examination revealed mild weakness in a left L5 distribution with 4 out of 5 left hip abduction, dorsiflexion, and plantar flexion of the left foot. Normal deep tendon reflexes and increased lower back pain with forward spinal flexion and left lateral flexion. She demonstrated normal ambulation without assistance. A lumbar discogram revealed discogenic low back pain generation at L4-5 with 8 out of 10 in intensity, relieved to baseline after 0.5 milliliters of intradiscal lidocaine. Her preoperative MRI T2 axial cuts show mild bilateral neuroforaminal narrowing at L4-5 and a disc bulge at L5-S1 with left neuroforaminal narrowing. Given that the patient failed to respond to conservative treatment, including injections, an L4 to S1 robotically assisted minimally invasive TLIF was recommended to address her lumbar spondylosis and L5 radiculopathy. All the relevant equipment, including the Mazor X robotic workstation and Jackson table, were prepared. The patient was brought into the operating room, placed under general endotracheal anesthesia, and positioned prone on the Jackson table. After inserting interbody cages at L4-5 and L5-S1 under fluoroscopic guidance, we inserted a docking pin into the right posterior superior iliac spine and moved the robotic arm into position, attaching it to the docking pin and registered the neuronavigation stealth system. We subsequently shot AP and oblique fluoroscopic images that were subsequently transferred onto the robotic station. We then moved the robotic arm into place for insertion of the left pedicle screws. Through the robotic arm, under stealth guidance, we inserted the left L4, L5, and S1 screws. We then moved the robotic arm onto the right side and marked the incision for our L4 to S1 right-sided pedicle screws. Skin incision was made, and then through the robotic arm, the screws were inserted. We then shot AP and lateral fluoroscopic images, which showed good placement of the screws and cages. We then removed the docking pin and robotic arm from the surgical field. Hemostasis was achieved, and wound closure was performed in anatomic layers. X-rays on postoperative day number 2 demonstrated excellent position of the hardware and maintained spinal alignment. The patient tolerated the procedure with no complications and went home on postoperative day number 3. She went home neurologically intact with improvement of her left leg weakness and lower back pain.